found in children's and terminal ill patients. It causes no trouble since the eyelid is rolled upward. The Bell's phenomena simultaneously during the sleep. Signs: facial palsy, ptosis, and thyroid exophthalmia. Coma patients and psychiatrical deformations of the upper eyelid. Symptoms are eye is red, irritable and watery, dryness and lower part of the bulbar conjunctiva and cornea. Explore keratitis, corneal ulceration, and corneal perforations are the symptoms. The eye are seen in a red color, they are irritable and watery eye. Maybe it's dry in cornea and bulbar conjunctiva is in lower part, mostly dryness. Explore keratitis is a corneal ulcerations and corneal perforation. Treatments is notable. It does not require any treatment. Installation of artificial tears at the day and antibiotic ointments at night is required, preventing the corneal drying. And closure of lid is adhesive tapes is used, and soft corneal lens is allowed the artificial preventively explored keratitis. And temporary or permanent adhesives is creating between the upper and lower lid, which may be laterally and paracentral. And lid lot operation is a gold plated used for the facial palsy. Treatment is caused by the ptosis due to the orbital tumors of the thyroid exophthalmia. And next one is symblepharon. Symblepharon, in these conditions, the adhesion of the lid to the globe as a result of adhesion between the bulbar and palpebral conjunctiva. Its main condition is adhesion of the lid to the globe. It's a result in adhesion between the bulbar and palpebral conjunctiva. Etiology is any cause which produce the raw surface upon the opponent area of bulbar and palpebral conjunctiva, which leads to the adhesion produces the healing procedure. It's mainly caused by the chemical burns. It's mostly alkene, terminal burns, and membranes conjunctivitis, ocular, psychiatrical, and Stevens-Jones syndromes, and postoperative antrotrauma. And next one is pathology. The brand of fibrous tissues are formed and stretching between the lid and the globe. The bond may be narrow or broad. The cornea is also involved in a severe cases. Types. There are three types of symblepharons are as following. Anterior symblepharon, the band are limited in a anterior part and involved in a pharynx. And posterior symblepharon band is obliquely at the pharynx only. Or the total symblepharon, the lid are completely placed against the globe and leaving a small fixation of palpebral aperture. Symptoms: pain and redness due to the exploration, watering, due to inadequate lacrimal drainage, diplopia due to limitation of ocular movements result in a pronounced adhesion, and cosmetic disfigurement. These are all the symptoms. Main symptoms are pain, redness, and watering, diplopia may cause, and cosmetic disfigurations are present as we see in the figure. And next one is signs. A signs of exploration, restriction of ocular movement, is visibility of fibroid band and obliquity of pharynx at the place. In signs, we can see the ocular movement are less and the visible fibroid bands are seen. The main signs are exploration. And the treatment is prevention is most important. Sewing of glass rod well coated with ointments around the upper and lower pharynx so that they are well packed with the ointments, which procedure is repeated several times each day according to severity. And clear contact lens is shield fitting separately the two mucal surface, preventing their adhesions. If it is extensive. The radical excision of the scarred of conjunctival tissue, mucous membrane graft to cover the bar area. Mucous membrane takes from the upper phoenix to the opposite eye of the bulcal mucus. Preventions of a recurrence of adhesives by therapeutic contact lens by scleral shell at least for 6 weeks. High dose of steroids is local systemic. It's helpful to prevent the formation of excessive granular tissue. And next one is ptosis. It is signification of drooping of eyelid, upper eyelid, which is unilateral or bilateral or partial or complete. In ptosis, the eyelid is halfly drooped or closed. Main etiology is congenital ptosis due to the imperfection differentiations of elevator muscles, often associated with the weakness of underlying a superior rectus muscles, elevator muscles together with the pen rectus of late extraocular muscles difference. Often hereditary dominance may be associated with the epicanthus and the biflophus, maybe is associated with the synthetic ptosis. Marcus Gunn, Joe Winglin phenomena. There are retractions ptosis eyelid is stimulate the muscles. Misdirections of third nerve, retraction of upper lid with the various ocular movement. Next one is aquatosis, is a neurogenic, partial and complete third nerve palsy and Horner's symptoms. Myogenic is myasthenic gravis, ocular myopathies and bilateral challengosis. Mechanical is excessive of a weight due to the edema of tumor, large calations, conjunctival scarring, blepharospasm of a upper lid. Traumatic is elevator trauma to the elevator muscles and post-surgical, example after cataract surgery. And clinical evaluations of ptosis is history is age of onset, family history, presence of diplopia, availability of variability of ptosis and symptoms of systemic problems, any contributing factors. Examination amount of ptosis is by noticing the ptosis lid margin with respect to the limbus and pupils. The mild ptosis is 2 mm, as moderate ptosis is 3 mm and severe ptosis is 4 mm or more. In ptosis measurement, first one is marginal reflex distance. Marginal reflex distance 1 is a distance in mm from the light reflects on a patient's cornea to the level of the central of the upper lid margins with the patient seeing in a primary case. As we showed in a figure, we can see that the reflex of the light from that distance to the upper lid of that distance is known as marginal reflex distance 1. The eye is examiner and the patients are at the same level. The light held in examiner hand to directly towards the globe of the patients. If the reflection is not seen, then the number of mm of eyelid raised to then recurrent of MR1 negative value. The amount of ptosis is unilateral cases in a difference between MRD1 and the ptosis side of the that in a normal side. In bilateral case, the MRD1 is separated from the normal MRD1. For example, 4 minus 4.5. And MRD2 is a measurement of the corneal light reflex of the center to the lower lid with the patient seeing in a primary case. A measurement is greater than 5 mm is considered normal. The sum of the MRD is 1 and sum MRD2 is equal to the palpable fissures width. In MRD2, we can taking the distance from the center of the corneal reflex to the lower lid. That distance is known as MRD2. and the sum of the MRD1 and MRD2 is equal to the palpable fissures width. And second one is MRD3 is the distance of the ocular light reflects to the center of the upper lid margin when the patient look extremely down cases. When patients is looking in down cases, that time we are taking the distance from the center of the to the upper glaze. Generally MRD3 is equal to the MRD1, but the associated of the superior retinal weakness or paralysis, MRD3 is more than MRD1. If any weakness or paralysis is present, the MRD3 is more than MRD1. Actually, it's in normal case MRD1 and MRD3 are equal. Next one is marginal limbal distance, or MLD is a distance from a 6 o'clock limbus of the center of the upper lid margin when the patient is look in extremely up case. It is about is 9.0 mm. The difference in MLD between the two sides of unilateral cases, or the difference with a normal or bilateral cases a multiple by the 3 would give the amount of elevator retractions is required. And next one is marginal grace distance is MCD, or MCD is a distance from the upper eyelid margin to the lid grace measures in down gazes. In a woman is normal central MCD is measured is about 8 to 10 mm. In normal in female our value is 8 to 10 mm, and in men is about is 5 to 7 mm. It is help to planning the surgical sections when the more than one lid creases are presented is more prominent. One is to be considered. Marginal crease distance is mainly used in ptosis surgery for planning a surgical sections. And palpable fissures height, or PFH, is a distance between the upper and lower lid in a vertical alignment of the pupillary center. A normal value for women are 9 to 10 mm. In men's is 7 to 10 mm in primary case. An upper lid is 2 mm below the superior limbus, and lower lid is 1 mm above the inferior limbus. Should be examined in a primary gaze, up gaze and down gaze. The amount of ptosis is different in a palpable apertures and unilateral ptosis, or difference from a normal in a bilateral ptosis. And ptosis lid is congenital. Unilateral ptosis is usually high in a down gazes due to the failure of elevator to relax. Ptosis lid is acquired ptosis is a invariably lower than the normal lid in a down case. These all are in the values are given for surgical sections for measuring the ptosis. And assessment of elevator muscles. How to assess the elevator muscles are: the brow is immovable to pressure with the thumb. We want to give the pressure to the brow with the thumb. The patient is asked to look down and then look up. The amount of extensions of the down up lid margin is then is measured with the ruler. The 2 mm of movement is contributed by the superior rectus muscles. In normal value is 50 mm is good, is 8 mm or more. This fair is 5 to 7 mm is very poor. In 4 mm 2 or less is very poor amount of elevator functions. An ocular mortality test we want to test: angiomegaly phenomena, Bell's phenomena, is photographies, and preoperative records, corneal sensitivity of neurogenic ptosis, and TENS test is the exclusion of migraines gravis, improve the ptosis with intravenous injections of are given for ptosis. These all are the treatments and tests we can take for the elevator functions. of the eyelid. The neurologic evaluations of a ptosis is neogenic. Next one is treatment for ptosis. First one, fascial servant preparations. It is a simple tasso corneal resection is useful in mild ptosis and good elevator functions in horror symptoms. An elevator resection is useful in a congenital unilateral ptosis with fair or good elevator functions. This may be in we can that the procedure is given in this figure. First one is that given in fascial servants operations. It mainly done in the upper lid. The skin approaches especially where the large resections is necessary. Conjunctival approaches is particularly useful in the moderate resections of psoriasis. Brow subsidence is bilateral case where the elevator actions is poor. Here the tarsals is fixation of a frontal muscles, YY is simply unobservable materials. This figure is showing that the how the procedure is done in treatment, elevator sections and fascial operation surgically. Thank you.